joint health. So let's give him a round of applause.
All right, well, thank you so much. Can everybody hear me?
Yes.
I don't think the microphone's on. Is it? Can everybody hear me?
Yeah.
Yes.
All right, I just stand a little closer.
Yeah.
All right, how many people here have a joint problem? I think just about everybody, and maybe people just didn't hear the question. All right, well, I'm Dr. Colin Kingston, I'm with Tidewater Orthopaedics. Next slide. So just a little bit about a little background. You know, today we're going to talk about joints and maintaining the health of your joints and things that can be done. But we're going to talk a little bit about the background to how your joint may present and the difference between sometimes the different manifestations of joint pain. I was a former flight surgeon. I was in the Air Force for the first 16 years of my career, and I've been in private practice here since 2003, and I see a lot of familiar faces out there, so some faces out there are patients of mine. All right, next slide. Our group, a little bit about our group. I had a patient earlier today to see one of my partners, and he was just asking some questions about some things. So we have 9 orthopedic surgeons in our group, which makes us one of the largest groups in the area. And one of the things that we focus in on is subspecialty care. And what that means is that no orthopedic surgeon can be an expert at every joint. And so what our group is really focused in on is, what are you really good at as a surgeon, and then do that joint, and do that joint up right. And that's something that we take pride on. We do have actually 3 now locations. We have a location in Williamsburg, which I came from this morning. We have a location in Hampton, which I'll be going to this afternoon. And we have now a 3rd satellite place in Suffolk. So we have 3 locations right now. Next slide. So definitions, arthritis. You know, a lot of times when we use medical words, you just got to break them down. ITIS, who knows what ITS means at the end of a medical word? Huh? Infection. Infection, no. Inflammation. Inflammation. So inflammation. So anytime you see ITIS at the end of any medical term, it means inflammation of that structure. Arthro means joint. So, but actually it's a bad name because not everybody with arthritis has an inflamed joint. So, better name for it actually is called degenerative joint disease, where the cartilage is actually breaking down, not necessarily where your joint is inflamed. Now there are inflammatory forms of arthritis, like rheumatoid arthritis. How many people have heard of rheumatoid arthritis? Quite a few of you. Psoriatic arthritis, gout. How many people have heard of gout? Okay, and pseudogout, right? Pseudogout looks like gout, acts like gout, but it has nothing to do with what you're eating or what your genes are. It has everything to do with aging. Anybody in their 90s here today has pseudogout, whether they know it or not. 100% of people in their 90s will have pseudogout. About 1 or 2 of us in their 80s will have pseudogout. In their 70s, about 1 out of 5. So it goes up exponentially as we age. Bursitis, okay, so ITIS means inflammation, right? Bursa, who knows what a bursa is? We've all heard of it, right?
Yeah.
Well, they're fluid-filled sacs that cushion where our tendons attach to bone. And sometimes they can be inflamed also. And we'll talk a little bit about this. Next slide. So arthritis, you have on the right side of the slide what a normal joint would be, normal cartilage, the lining of the joint called synovium. On the other side, you see the cartilage starting to wear away. You're starting having, sometimes inflammation, sometimes swelling, but not always. Next slide. So there's different stages of arthritis. I don't expect anybody to memorize this or know it, but a lot of times as orthopedic surgeons, we'll grade your arthritis. And sometimes we make it more simple than rather than saying 1 through 4, we'll say that you either have mild, moderate, or severe arthritis. Severe arthritis being bone on bone, and some of you out there probably heard of bone on bone arthritis. That's the severe form. Next. So again, you have on the right side of the slide what a normal healthy joint would look like. Normal cartilage gets its nutrition not from blood. When you look at structures in the human body, things that are red, like muscle, tends to have a very good blood supply. Things that are white, like cartilage, don't have a very good blood supply. So the problem is when we injure our cartilage or our cartilage starts to degrade, it doesn't grow back because it doesn't have a very good blood supply. So how does cartilage get its nutrition? It gets its nutrition through fluid called synovial fluid from cells that line our joints that make that fluid. So how do our cells get stimulated to make that fluid? And one take-home message that I'll say over and over again throughout my talk today is motion. Motion stimulates our cells to make that fluid, to give our cartilage the nutrition. So moving, moving, moving. Motion is the key to a healthy joint. And what you don't want is on the left-hand side of that slide where you have inflammation, cartilage just deteriorating, and a lot of pain. And then the top part of that slide, bony erosion. People always say, gosh, Dr. Kingston, if I got severe bone and arthritis, can it get worse? The answer is yes. It gets worse because you start wearing out the bone. Okay, next slide. So again, bursitis or fluid-filled sacs. The knee on that right slide shows a healthy knee. It only shows 3 bursa. We actually have over 15 bursa around our knee. So it's just a simplified cartoon version. But the version on the left shows what happens is when the bursa becomes inflamed, the ITIS portion of that word.
That's on the right.
On your right, yes, but yes, thank you. Right and left, right and left, yes. Wow, scary, right? I know my right from the left, but you're right, thank you. On your right, on my left, yes. Okay, so next slide. So here's some x-rays of what arthritis looks like. Osteoarthritis on the right side, sorry, on the left side, thank you. Shows that you have bone-on-bone arthritis there, and on the left side of the slide where it says rheumatoid arthritis acts differently in that our immune system starts attacking the lining of our joint, and then there's collateral damage that occurs to the cartilage in the joint. So it appears differently on an x-ray. So a lot of times, as an orthopedic surgeon, if I get an x-ray, I can tell if somebody has osteoarthritis, the most common form of arthritis, or rheumatoid arthritis. Next slide. And again, this is just looking at the hip joint. Again, a healthy hip joint on the left, and a very arthritic hip joint on the right that's bone-on-bone, the severe category. And you can see on the left, there's a little bit of space between the ball and socket of the joint. On the right, it's obliterated. Next slide. So this is what bursitis looks like. That's a knee, and it doesn't look like a knee, right? It looks really swollen, really painful, and it can be extremely painful. Next slide. So one of the things that I can't emphasize, we're talking about healthy joints today, staying active. Remember one of the key words I said earlier, right? Motion, 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 motion. Moving is important. Even when people with arthritis can move and get out there and exercise. Sometimes walking may be difficult, but what everybody in this room can do is get in a heated pool and walk in a heated pool. Water aerobics is, to me, one of the best form of exercises. The buoyancy of the water decreases any loads you're putting across your joints. The resistance of the water helps tone up your muscles, and you feel good. So motion is important. Losing weight, obesity is becoming a pandemic in our country. It's getting more and more difficult, and let's face it, every decade of life, it gets harder and harder to lose weight because our metabolism slows down. When our metabolism slows down, you just smell coffee cake and you gain 10 pounds. You're like, how did that happen? Eating smaller portions more often, and when we talk about diets, diets come and go. Everybody's heard of the Atkins diet. What's making the press now is the keto diet, and what's making the press now is also intermittent fasting. Well, they all have their merits, but really I think the key to dieting is never go on a diet, but actually just eat healthier, and eat smaller portions, more vegetables, less fatty foods, and less snacking. Unless it's healthy snacks. Next slide. So management of pain. There's not one person that doesn't come to me as an orthopedic surgeon that's not in pain. People don't care if they have arthritis. If it doesn't hurt, if it ain't broke, don't fix it, right? You're not going to come see me if you're not in pain. So pain, the first thing that I tell people when you do have pain, the first thing you should always do is the acronym RICE. Rest, ice, compression, and elevation. And then sometimes taking an anti-inflammatory medication. Now you have to sometimes be careful Because just like with any medication, and most of us here in this room are probably on at least 1 or 2 medications, you always have to be worried about drug-to-drug interactions. You have to be worried about what it can do to other systems that you don't want to affect. So I tell everybody, even over-the-counter medications, if you're over the age of 65, you should probably always run it by your doctor before you start taking a medication, because serious side effects can occur. But medication can be helpful also in managing pain and inflammation. And then where do I come in as an orthopedic surgeon? Well, there are things that I can do to help treat arthritis non-operatively, like cortisone injections. Everybody's heard of a cortisone injection? Yes. So cortisone, what does it do? It's a steroid that helps with pain and inflammation. But it doesn't do anything to actually address the arthritis or the cartilage damage. So, but it does help with the pain and inflammation. So what does it help you do? It helps you stay active and move. So to me, I have a lot of patients, for example, who are not candidates for surgery, that have a lot of pain and they have trouble moving. Well, I give them cortisone shots sometimes every 3 to 4 months just to keep them moving and keep them active and keep them independent. Viscosupplementation is a fancy word, and that just means gel injections. How many people have heard of gel injections? Okay, so a lot of the companies are really marketing and advertising them big time. I like gel injections. The problem with gel injections is they don't really work when you have bone-on-bone arthritis, because bone doesn't get lubricated with the gel, cartilage does. So you do need to have some degree of cartilage still left in your joint for the gel injections to work. And some insurance companies, unfortunately, lately are taking some of that data that was studies that were done on bone-on-bone arthritis, and they're no longer improving gel-on-gel injections. And so that's unfortunate for me, because then it inhibits my ability to offer those patients with that particular insurance gel injections, but I think it's a nice guy. Then platelet-rich plasma and stem cell injections. How many people have heard of these? Some people, okay, not a lot, not as many. It's making the press now. It's still deemed by the FDA to be experimental. Platelet-rich plasma basically is when you take blood from somebody's arm, you spin it down, you take your own growth factors from your own blood, you concentrate them, and then you inject that into a joint. The reason why it's not FDA approved is those studies are still ongoing. They haven't been proved necessarily to be completely beneficial. But because it is deemed experimental, no insurance company right now in 2020 will pay for it. But we do offer it as a potential option with the knowledge that this is deemed experimental. You know, let's face it, if you have no other choices, you're hurting, you don't want surgery, you're not a candidate for surgery, this may still be a viable option for someone. Stem cell injections have, basically stem cells are cells that basically can be turned into anything. So to me, stem cell is the future of medicine, it really is. The problem is we don't know enough about them, to be quite frank with you, and that's why it's still deemed experimental. And there's still ongoing studies with stem cells. Next slide. So, to me as a surgeon, when do I even consider doing surgery on somebody? Well, when we try all these other things first, and they fail. And more importantly, I tell people what matters to me most is your joint pain interfering with the quality of your life? If it is, then considering having a joint replaced would be reasonable, as long as we've tried everything else and it's interfering with the quality of life. You know, I don't think anybody wants to live a long life and suffer. People would rather not suffer and have a quality of life. And I think that that's what sometimes surgery can offer. And then at the bottom there, I said my rule of pens. Remember we talked about with arthritis, sometimes it can get so bad that you can start wearing out your bone. And I have patients with knee problems, and I'll try to show everybody, that sometimes they wait so long that their knee now is like this, or they're walking like this, because their knees are so bowed, and they're beyond 10 degrees. Well, as a surgeon, for me to correct that kind of deformity, I have to basically release so many structures to get that leg straight that they're not going to do as well as somebody who wasn't as bad and worn out their bone. So sometimes there's what I talk about, a window of opportunity to have surgery. And sometimes people wait too long. Sometimes patients come in a wheelchair, for example, and they haven't walked in about 2 to 3 years. Oftentimes those patients aren't healthy enough to have the surgery. Next slide. So when should you consider it? Again, we talked about this. Nighttime pain is also can be a problem. Let's face it, if we don't sleep because our joints hurting, our quality of life is not there. You're tired, you're fatigued all the time. Next slide. So clinical outcomes, and this is something that you'll hear more and more about. And I think that one of the things that there's so much misinformation out there. When we look at a limited amount of money that, for example, Medicaid, Medicare has, sooner or later the government's going to have to decide what are we going to allow to happen with elective operations and what we are not going to allow to have elective operations. And there's a statistical analysis called calculated adjusted quality years of life. And it's a very fancy way of saying where do you get the most bang for your buck. And so when you start looking at, for example, surgeries, which are very expensive, you have to start saying, is this really worth it? The expense really worth it in improving somebody's quality of life? So the ultimate multi-million-dollar question, who can tell me what has the best bang for your buck operation in the world? Any guesses? I don't hear anybody. I'll give the answer. Knee replacement, okay, so knee replacement in the front row. That's the second. That's number 2 on the list. So knee replacement, hip is number 10 on the list. Number one is not my specialty. Cataract surgery.
This lady said facelift.
Facelift. The plastic surgeons would love that. But so cataract surgery. So if we can't see, our quality of life goes down tremendously. So being able to see is very important. The second, probably most important thing that we sometimes take for granted is mobility. And that's where orthopedics comes in, and that's where knee replacement is number 2. And so when they do the statistical analysis, when you talk about bypass surgery for your heart, for example, knee replacement surgery improves the quality of your life 15 times greater than bypass surgery. So when you think about healthcare systems that have to look at a limited amount of dollars and what they're going to spend it on, they're going to spend it on cataract surgery and knee replacement surgery, but not necessarily bypass surgery. And this is again something that you'll probably hear more and more about as the dollars for Medicaid and Medicare continue to shrink. A couple of things about knee replacement surgery. In my experience is that there's a lot of misinformation, and I would tell you a lot of my patients, the vast majority of them, when I replace their joint, choose to have their other joint replaced, and that should tell me everything. There was another surgeon in town who used to tell me, "Oh gosh, I always do both sides at the same time," and I'm like, why?
Yeah, really.
And his comment, and of course I won't tell you who he is, but his comment to me was, well, if I do one, they may not want to have the other one done. And I said, well, if you do it right, they'll probably want to have the other one done. And, so to me, I have not done bilateral knee or hip replacements since 2007. And that's the last time I did it, and that's only because a patient talked me into doing it. But I don't do both hips for that reason. Next slide. So again, the whole thing here is, I think that your preoperative pain, when you talk about clinical outcomes, it takes a while to get over knee replacement surgery. Despite all the improvements in technology, the first month is still tough. The second month gets better, and I tell people by the third month you start liking me again. So always keep that in mind. So it does take a lot of time to get over the operation. But the outcomes are very good. Next slide. So hip, some of you here probably have had a hip replacement surgery. Hip replacement surgery in general, comparing to knee replacement surgery, people recover faster. It tends to be less painful, not as nearly as complicated, but there are some unique complications to hip replacement surgery that you don't see with knee replacement surgery, like leg length discrepancy. In the knee, we can't really lengthen the knee. People that I do knee replacement surgery on them will tell me, my knee feels longer. But the reason why it feels longer is because I straightened it out. It was crooked and it's straighter. So if this is my knee and I go like this, my fingers are still the same length, but the distance from my wrist my fingers longer. So you don't do it. But in the hip, you're not limited by lengthening the leg. So people, and some people with really severe congenital hip problems that had a leg length discrepancy to begin with of up to 2 to 3 inches, you can actually correct that deficit and make their legs even with a hip replacement. So you're not quite limited. The only thing you're limited really with hip replacement and lengthening the leg is the nerve. You don't want to stretch the nerve too much and have the foot drop because of that. So that's really the only limiting factor as far as lengthening the leg with hip replacement surgery. Next slide. So this is a question I get asked all the time, and this is just a fairly good estimate. You know, I went to medical school in the 80s. I did my orthopedic training in the 90s, and I can tell you that from the 90s until now, things have changed dramatically. You know, when I started doing knee replacement surgery, for example, back then the patient would be admitted 2 days before the surgery for a medical workup to make sure it was safe. We would do an epidural. They would stay in bed. We'd put them in a machine to move their leg, and they would stay in bed for 2 to 3 days. And then we were shocked why they had pneumonia, why they had blood clots, why our infection rate was 1 to 2%. And we realized, you know, what was the first word that I said that I want you all to remember? Motion. Getting up, getting moving. As human beings, we need to get up and get moved. And now it's gone almost 360 degrees. You know, since 2015, I started doing outpatient knee replacement surgery. People have their knee and they go home 2 to 3 hours later because they're able to do so, because the improvements in technology and the improvements in the post-operative pain, which I think is very, very important. And I think you'll see more and more and more of that as time goes on. Two insurance companies right now, we have to justify to the insurance company to keep the patient even for 1 night now. Pre-authorization before we do their hip or knee replacement, because those are the kind of improvements we've made. But let's face it, somebody who's 85 years old who has 4 or 5 medical problems and on a list of medications, that's the last person that I want to go home and not keep an eye on overnight. So despite some of these positive changes, as a surgeon, as a doctor, I still have to fight the trends, because some of these trends are being caused for financial reasons. It's cheaper to go home that day than spend a couple of days, for example, in the hospital. Next slide. Okay, so my treatment rationale, I think that, you know, I think the key things is, you know, getting the pain under control. One of the unique things that we do, and you may have heard this word before, preemptive anesthesia. A lot of our patients will get blocks before we do the surgery. A block means that the anesthesiologist is numbing up that joint beforehand. So the concept there is you're taking away pain before you start pain as a surgeon. And post-operatively, patients do much better even after the block wears off, because you already started taking away the pain before you started it. So it's not a unique concept, but it's something that's been going on for the past decade or so, but it's getting better and better and better. And that's why you're seeing, I think, better outcomes and people recovering faster. Next slide. Next slide. So again, outcomes. You know, one of the things that we're proud of is here in Hampton, we created the first orthopedic hospital in the region. And the reason why we did this back in 2010 is we realized that orthopedics is becoming more and more specialized, and not everybody can be an expert at every joint. And by doing this, we also got specialized teams. You know, I tell people I think I'm a pretty good quarterback, to use a football analogy, but if you don't have a good team around you, you're going to get sacked. So we now have teams that are so specialized that, for example, when I do a knee replacement, I never have to ask for an instrument. They already, the surgical technician already knows the process, the procedure, and it's just makes it, it's like, you know, flying an airplane autopilot. It makes it so much easier for me as the pilot or as the quarterback to do the operation, and I think it really does affect outcomes. You know, we have at our hospital one of the lowest infection rates in the Commonwealth of Virginia and in the United States. Our infection rate is below 0.1%. The average is 1% in the United States. So that's a significant, improvement that we've made from 2007 to 2010 when we were getting this hospital built. Something that we're very proud of. And I would tell you that also there's something called HCAHPS scores. It's something that anybody who has a joint replacement will oftentimes be asked and surveyed by the government, you know, how do you rate your pain? How do you rate your joint replacement? They want to know the data. And right now, we're in the top 1% in the country for what our patients are rating their outcomes on their joint replacement. So again, it's something, I can't take total credit for that, I'm just one of 9, but it's something that, again, we're very proud of. So this is not what I'm saying, this is what our patients are saying about their outcome and their experience. Next slide. And that's it. I think that, you know, for me, a lot of times people come to this and they have their own specific questions, and they won't be able to answer everybody's question. But oftentimes, the person next to you may have the same question. So I find sometimes questions and answers to be probably the most helpful and most fruitful. So the one word that I want everybody to remember, motion, right? Move, move, move. Everyone in this room, get involved in an exercise program that you're capable of doing, you know, and try to move as much as you can. People like to travel, get up and move every hour. Otherwise you will get stiff and you will have pain, and you won't enjoy your trip nearly as much if you suffer. So I'm going to take questions. If people just raise their so we'll start from the front and work out back. So the question was, what do I think is the best devices for total fitness? To me, it's really simple. I believe in the Jack LaLanne, Herschel Walker mentality. Both Jack LaLanne and Herschel Walker. How many people know Herschel Walker? Running back, played for Georgia Bulldogs, made the NFL. I think played for Dallas for a little while.
Yay.
Herschel Walker is, sorry about that, being
No.
a Patriot fan here.
Cowboy.
But Herschel Walker doesn't lift weights. He doesn't go to necessarily a gym, but what he does push-ups, he does sit-ups, he does pull-ups. He uses his own body, and he gets in shape. Jack LaLanne, the founder of fitness, right? Everybody remembers Jack LaLanne. He lived to what, 90-something years old. At 80 years old, he pulled a train with his teeth to show how tough he is. You know, and he didn't, again, use weights or fancy things. I think that, you know, I think the gizmos and will come and go. I mean, how many people remember, what's it? It's Three's Company, the actress of Three's Company, the Thigh Master.
Oh, yeah, the thigh. Yeah.
You do this. And
Yeah.
He's a Thigh Master. It costs $29.99, but if you buy 2, it's $19.99. You'll get it now. How many people bought that, and how many people are still using it to this day? Nobody. I think that it's not so much the equipment as much as getting involved, doing exercises correctly. I tell people, you know, not everybody should be doing lunges where you're going down, all the way down, and then your knees almost touching the ground. For me, at 55, this is uncomfortable, and I know if I keep on doing 10 more, I'll be walking out limping, you know, in front of you all. But what can I do? I can do a partial lunge, and I can do a partial reversal lunge. So I'm still moving, but I'm doing the exercise within my joints' abilities. And I think that's what's critical, and that's why I think every exercise regimen should be individualized, but I think that getting out there doing the easiest form of exercise is walking, but not everybody here can walk and walk long distances. But like I said, what I said earlier, everybody here can get into a heated pool and walk in that heated pool. I have patients that are 600 or 700 pounds that have bone and bone arthritis that aren't candidates for knee replacement, for example, surgery. But we get them in the pool and they lose 50 pounds, they lose 75 pounds. 2 years later, they lost 150 pounds. And now they're getting closer to being able to have their knee replaced. But they got a nutritionist involved, a dietitian, they got a weight loss expert involved. You know, we all need sometimes help to meet our goals. But I think that your human body is the best. Yes, ma'am.
What is best put towards making arthritis, heat or cold ice?
Okay, so this is a great question because I didn't really mention any of my slides. The question was, what is the best, you know, treatment for arthritis, heat or ice? Heat helps dilate blood vessels and bring blood flow to us. Most of us, as we get older, heat tends to feel much better. Heat is very good in the morning, I think, and if you've been sitting for a long period of time, heat will help warm up the joint, make it feel good, bring blood flow. The problem with heat is if you're swollen and you have an inflamed joint, it's going to make it more swollen and more painful. So heat is very good for warming up joints and joints that are stiff and achy. but ice is very good for inflamed, swollen joints. And so a lot of us, sometimes as the day goes on, our knee will become swollen and painful. So in general, at night, using ice will be helpful, but in the morning, heat will be a thing. So sometimes it just depends on what your joint is doing. And hopefully that answers your question. Okay, yes, in the back.
Will you please tell them about new flexor for pain management? I love it.
Okay, so somebody who I know very well in the back, basically, it wasn't so much a question as much as a statement. That please tell everybody about Uflexa for pain management for joint arthritis. And what Uflexa is one brand name of a type of gel that you can inject into the joint. And so we'll talk a little bit about that. Gel injections work differently than cortisone. Cortisone helps with pain and inflammation, but doesn't do anything to the friction of your joint. When you think of arthritis, the cartilage is starting to wear out, and the cartilage doesn't have the ability to hold onto the natural gel that's made in our knee. So the gel, actually, from gravity, settles. That's why a lot of us that have been sitting here listening to me talk for the last half hour go to get up. Oh boy, the first couple of steps, you're a little stiff, and once you get going, you're fine. Because then the fluid finally gets back into the joint and moves it. What the gel injections do is exactly that. It helps lubricate the joint, but what it does long term, or attempts to do long term, is stimulate the cells that make the gel, the natural gel, to make the same stuff. In other words, it tries to fool those cells, tell them stop making those degradative enzymes that are going to break down cartilage. Just start making the good gel stuff. And so it fools, F-O-O-L-S, fools our cells into making the same gel and helps lubricate our joints. So it works, but it works for people with mild to moderate arthritis. In general, it doesn't work that much with people with bone-on-bone arthritis and no cartilage left in their joint. Okay, yes, ma'am.
Yeah, as far as pain, could you address how do the CBD oil work as far as pain?
Okay.
And the cream.
Okay, so the question was, and this is something that I didn't put in my slide, how does CBD oil work for addressing pain? CBD oil is becoming more and more commonplace as things like Colorado and other states that are getting restrictions on marijuana and some of the positive effects from marijuana and CBD oil. Can it be effective? The question like that, I think, is complicated because there haven't been really good double-blinded studies, which are considered the best form of studies looking at CBD oil, but they're ongoing right now. And so we'll know if it's really much, much better than a placebo. Everybody knows what a placebo is. Sugar pill, and this is what we test everything against. I would tell people, if it works, for you, then great, it works for you, and then it's worth getting. And for some states, you have to have a prescription for it. Other states, you do not. I have a friend of mine who had a stroke, who has contracted joints, and he tried the CBD oil, but it didn't work for him. But his problem, his pain is not coming from his joint, his problem's coming from his brain where he had the stroke. So a lot of these topical medications won't work. There's other topical medications that are out there also, a whole host of them, and they all work in different ways. And sometimes, and again, it gets back to the individual. What works for the person next to you doesn't necessarily work for you. You have to figure out sometimes what works best for you. Yes, somebody over here, yes.
The gel injections, can you use that for the hip also?
Okay, so the gel injections, can I use that for the hip also? And unfortunately, the FDA has not approved it for any other joint than the knee. Now, there's studies going out there for the hip and shoulder, but people don't realize it takes sometimes 10 to 15 years before the FDA will approve something like that to make sure it's safe to be used in that joint. Now, there's quote-unquote off-label indications where, as an individual, if you wanted to pay cash for it, that it can still be done because it's not unethical, because we know it's safe in the knee, which is the largest joint in the body. Chances are it's going to be very safe in the hip as well. But right now, as of this date right now, 2020, it's not approved for the hip or shoulder, but I suspect it will probably be soon. And that might be 6 months, that might be a year, that might be 2 years, but I don't know the exact date. Okay, some of you on this side of the room. Yes, sir, in the hat.
We got two parts. What do you think about glucosamine? Is that good and good, you know of? That same true up there, same day appointment?
Yeah, same day appointments. So we have 5 same day appointments that we reserve for people with acute problems. What I mean by acute problems, I fell, I have more pain, more swelling in my knee. I don't want to go to the emergency room and wait 6 hours. We'll get people in. But if you say, I've been putting up with lower back pain for 2 years, and I want an appointment today, we won't fill that slot. So we reserve those slots for people with acute problems. So yes, we do have, and every surgeon in our group has 5 slots open. The only other problem sometimes that happens, like today, it happened with me because I'm giving this lecture today. All 5 of my slots are already taken today. So if you call after this, lecture and say, I want an appointment with you today, I heard about the same day appointments, they're already taken, so you won't be able to get that appointment with me today, but yes, we do have that. So his other question was, does glucosamine and chondroitin sulfate, which they tend to be paired, good? We didn't really talk about that much in any slide, but glucosamine and chondroitin sulfate are basically the building blocks of cartilage. And they really came about 15 years ago, 20 years ago, started gaining popularity, and people started taking and noticing an improvement in their joint symptoms. And then there's a guy named Steve Arnowski, who's considered a cartilage expert, leading cartilage expert in the world out of Michigan. Gave a recent lecture at one of the academy meetings that I went to, and the problem with cartilage, it doesn't regenerate, it doesn't grow back. So just because you're eating building blocks, does that mean you're now going to grow that cartilage back and use those building blocks? And so he gave me the analogy, and I've got male pattern baldness on top of my head, of eating hair. If I eat hair, it has keratin, it has protein, it has all the things in it to grow hair. But just because I'm eating it doesn't mean I'm going to grow the hair back on the top of my head. So, but I do have patients that do take chondroitin sulfate and glucosamine and swear by it and say it helps me tremendously. So who am I to knock that? I tell them, if it works, I know it's not doing any harm, and if it helps, then great. So I tell everybody, if you try glucosamine and chondroitin sulfate, try it for a month. If 1 month you don't notice a significant improvement in your joint systems, then don't waste your money anymore.
Do you only do hip and knee, and which of those do you do most?
Okay, so the question was, do I only do hip and knee, and do I do any other joint replacement? I used to do, when I was in the Air Force, and then when I got out of the Air Force, I used to do a little bit of everything. I used to do shoulder replacement, elbow replacement, hip and knee replacement, and what I found that I was much better at doing hips and knees than I was doing an elbow and shoulder replacement. Although I do a lot of shoulder surgery, I don't do shoulder replacement anymore because quite frankly, I have 2 partners. One of my partners is seeing one of our patients who does a much better job at shoulder replacement than I do. And I've always promised myself, if there's somebody in town that does a better job at me, I'm going to refer my patients to that doctor, whether in my group or not in my group. The other question, the other caveat to that question is, what do I do more of, hips or knees? 750,000 knees are being done in the United States every year, and 250,000 hips are being done. So almost 3 times as many knee replacements as hip replacements. And in my practice, it's about that. I actually do probably about 5 knees for every 1 hip that I do. But it's just because of the nature of the joint, and people are more likely to have knee arthritis than they are hip arthritis. Okay, somebody on this side. Oh, sorry. My back was to you. I'm sorry.
What's the average length of time for a hip replacement?
Okay, so the question was, what's the average time for a hip replacement to last? I had that slide up earlier, but in general, hips that we're putting in today, we think are going to last 25 to 30 years. Hips that I put in over 20 years ago, and I have enough experience to tell you now, it lasted in the lab 18 to 20 years, and lo and behold, they lasted for about 18 to 20 years. So if our laboratory data still holds true today, for example, the knee that I'm putting in now in the lab is lasting 33 years.
Wow.
So that to me is an A+++. So, but you're right, they're all finite. And why are they finite? Because anything that is man-made doesn't even come close to what we call the coefficient of friction, the friction between moving parts as a normal knee. We cannot replicate with any piston, any artificial intelligence, the coefficient of friction of a normal knee. A normal knee coefficient of friction is 50 times better than any man-made structure that moves against each other. So that should tell you something. So sooner or later, anything that's man-made will wear out. And so everything has a finite number, but that's a very good question. But that number will continue to change. And you know, in about every, I'd say in my experience, about every 4 to 5 years, there's been a significant technological breakthrough that may be allowing things to last even longer. Go ahead, you have it.
So can level of activity or amount of activity make a difference in terms of, you know, the years that might last?
Okay, so she also asked, is the level of activity going to affect the longevity of that implant? And the answer is yes. The problem is, we know this. We know that the cells that still line our joint, called synovial cells, still produce that gel even in an artificial joint. So the artificial joint still needs gel, still needs lubrication, right? Well, what did we say earlier that produces that? What stimulates to do that? Motion. So we know that motion is good, but we also know that motion, if there's friction there, will tend to wear something out faster. So the right answer is, you know, we don't know. You know, I do know that moving is important, and I do know that walking and doing low impact exercise is probably going to be very beneficial to your artificial joint. But high impact, like running, jumping, I tell people parachuting out of a perfectly good airplane, you know, all these are the things that I don't recommend, but do I have patients do it? Absolutely. You know, I had a patient who at 58 years old, she was something called an ultra runner. Have anybody heard of an ultra runner, the term? So ultra runners, so there's marathon runners, right? Marathon runners run about 26, 27 miles in a day. Ultra runners do that times 3 in a day. So they'll run 70 to 100 miles in a day. So they're addicted to running.
Yes.
And they push themselves to the limit of what the human body can withstand. But they're all athletes. And I had this patient who at 58 had worn out both her knees terribly. And she had significantly bowed legs. And I said, okay, my concern for you is not that you're not going to do well with the surgery. My concern for you, are you going to wear out your knees because you're going to go back to running? You know, and you're going to go back to doing this. I said, I'm not going to do your knee replacements and then in 5 years have your knees worn out and have to do revision surgery. And oh, by the way, revision surgery is not as good as the original surgery. When you have an operation like a joint replacement, you want one operation and you want that operation to last for the rest of your life, ideally. Now there's always exceptions to those rules. So for her, I told her, I said, the deal is this. I will do your knee replacements, but no more ultra running, no marathons, 5Ks only. If you can do 5Ks, and that's all you're gonna stick to, then I will do your knees. Now, she just so happened to go to an 8K run and cheated on me. And I kind of got wind that one of my patients was running in an 8K. And I said, you know, I have spies that are watching you. You know, 5Ks, that was the deal. So I don't know, she's now 2 years out, she's 60 years old now, so I don't know for the rest of my career, will she wear out her knees? I hope not. But that's a difficult question, but motion is good. So motion is good even for artificial joints. Artificial joints still need to be lubricated, okay? All right, somebody over here, yes.
Between the titanium and, like, say, your striker replacement?
Okay, so the question was, as far as the implant itself, Stryker is one type of brand name, and the other question was like titanium. Titanium is, when you look at all the elements, everybody here has probably taken a little bit of chemistry. You look at the element chart, there's elements that we use to build the implants, you know, and titanium is the closest to bone quality that there is. It moves a little bit, but it's also strong. It's actually stronger than bone, but still forgiving like bone. But bone oftentimes will get confused with something called titanium, three-dimensional titanium, and think it's bone and grow into it. So implants that I'm using in knees now, for example, have titanium in them, and that's why I use the Stryker system. But in the hip, I use Biomet. And the reason why I use another company called Biomet is because they have a plastic piece that has vitamin E in it. And vitamin E, we know, helps prevent what's called oxidation. It helps to prevent the breakdown of the plastic. You know, back in 2008, 2009, I was using metal-on-metal hips. And back then, we were told metal-on-metal hips is the best invention on the planet. They'll never wear out. And the problem with joint replacement surgery, it's the plastic that wears out, not the metal. The plastic that wears out. And we said, with metal-on-metal, these hips will last forever. Only to find out that the cup that they made was slightly smaller than the ball, and the ball would edge load and create little metal ions. And for a small percentage of patients, they would react to it as though their hip is infected. And I did 58 of those, unfortunately, in 2008, and then there was a recall, largely because surgeons like myself who follow up their patients reported back to the company saying there's a problem with your implant. I have 8 patients that have already failed their joint replacement, and that I've never had a hip fail before in my career. So, and their original response, well, Dr. Kingston, it's the way you're putting them in. And I said, oh, really? Well, then let me show you my x-rays and tell me what I did wrong. And they came back and they said, oh, maybe there's a mistake. And now there was other orthopedic surgeons reporting, and this is how a recall occurs. Same thing with a recall of a car. A mechanic senses something that's wrong in your car and says, this shouldn't happen, you know, with this particular device, and reports it back to the company. Well, it's not, if other mechanics don't start chiming in, there won't be a recall. But if other mechanics start chiming in, there's a recall. In joint replacement surgery, it's kind of like the same thing. So there was so to answer your question, the material that I use is based on what I think is best for that particular joint, and it's complicated, but I don't use metal-on-metal joint replacements anymore, even though the metal-on-metal joint replacements that I use with Biomet, not another company called Q, that are 20 years out, are still doing well. So again, I think doing your research, asking your surgeon, you know, what implant do you use and why, I think is very important. And that's something, a question that sometimes people forget to ask. Yes, sir, behind you.
So you said titanium was a good, I mean, the Stryker was a good one?
Yes, yes. I think Stryker is, to me, the best. And I'm not a consultant for Stryker or a consultant for any companies. Sometimes doctors are consultants for companies, and I chose not to be a consultant largely because I never want to be biased in my selection. And you know, and just like I don't use Stryker for hips, I use them for my knees. I use the best implant. But again, that's a question one-on-one you should always ask your doctor. Why do you use that implant, and what are the benefits and pros? Somebody in the back? Go ahead, yes, sir.
What are the sure signs of bursitis?
What are the sure signs of bursitis?
It hurts.
So bursitis will hurt. It will hurt right on that area. It'll be swollen and painful, and you could actually, I call it the Blotman test. You'll push on it, and there'll be like fluid. You can tell there's fluid there. And bursitis can be very painful. You get it on your elbows. It's a very common area. Elbow's probably the most common. The knee is probably the second most common joint to get bursitis. But you have bursitis, you try the rice, and in a couple of days it doesn't go away. Get seen.
What kind of surgery do you do for that?
For bursitis, I don't do surgery for bursitis. What I do for bursitis is I stick a needle in it, I draw the fluid off, and I put a little bit of cortisone in there, and that works 95% of the time. Rarely do I have to do, the times I have to do bursitis surgery, which we call a bursectomy. ECTOMY means removal of that tissue, when you see that on a medical word. So when you remove the bursa is when it's infected. Or I tried conservative treatment and the bursitis is still there. But I do bursectomies maybe once every 2 months, but I see at least 10 patients a week with bursitis. So it should tell you the odds are not necessarily leaning towards surgery. Most people get better with non-operative things. All right, we have time for 1 or 2 more questions. Go ahead. The question was, what is my procedure when somebody may develop scar tissue after having like knee replacement surgery? It's actually a fairly common problem, and it happens about 10% of the time. And people who have had multiple operations are more prone to getting it, but some people are just more prone to getting it because they form scars. Sometimes people, especially ladies out there that had their ears pierced, you may have a friend or two that may have like a big scar where they had their ear pierced. That person is more prone to developing scar tissue. So in general, what I usually do is, first thing is the RICE, right? Rest, ice, compression, elevation, physical therapy. If that fails, then sometimes what we do is we take people back to the operating room, we manipulate their knee to break up the scar tissue. If it comes back again for the third time, then sometimes, which happens to me about once every 2 or 3 years, I'll have to go in and scope their knee, and through a scope, no incisions, I'll clean up the scar tissue that way. All right, last question, go ahead.
I heard you say you're not particularly a shoulder person, but can you say is that common sense?
Yeah, I am a shoulder person, shoulder doctor. I do about 4 shoulder operations per week. I just don't do shoulder replacement surgery. But I do shoulder. So shoulders are very common. Rotator cuff tears are very common. The older we get, the more prone we're getting to. It might be as simple as reaching for something up in a cupboard, and it's heavier than you thought, and you feel this pull, and now your arm is weak and painful, and you have nighttime pain. It's hard to fall asleep. You go to reach for something, your arm doesn't feel like it's capable of holding up. These are all signs of rotator cuff tear pathology. And I tell people, always get looked at. Again, if you try the RICE and your symptoms persist, get seen. All right, well, that's all I have time for, everybody. I'll stay a little bit longer if you want to talk to me. Thank you.